What's going on? What's going on? Welcome to a late night edition of Kidney Disease Education Moment. I am your host, Steve Belcher. I won't be on here long. What I wanted to do was talk about three things. One was acute kidney injury and chronic kidney disease. The second was hospital discharge. And the third was quick access check. Now, you can't get this from nowhere else. 11 o'clock at night, I know it's late, but hey, there's no better time than now to do kidney disease education, especially if it can help kidney warriors. Now, not to get too deep into science and all that, but let's just talk briefly about AKI, acute kidney injury, and chronic kidney disease. Okay, so people with, before I start, share this broadcast, please. Let's get some people on here. I know some people got insomnia or something like that. They can't sleep. Hey, Bridget, thank you for watching. This is a great time if you can't sleep to get some good information. I don't care if you're transplant, pre-dialysis, on dialysis. This is some great information that you cannot get from the units. You can't get really from anywhere else unless you do your own research. And then if you're not really educated in this stuff, then how are you going to break it down and understand what you really need to know? So with that being said, let's just talk a little bit about AKI, or acute kidney injury. And again, I'm not a doctor. I'm a registered nurse. And let me just go into a little bit of legal stuff. I'm sorry, wrong banner. But the information broadcast on Urban Health Outreach Me is provided for educational and informational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Now, with that out the way, man, let's talk about this because this needs to be talked about. AKI, chronic kidney disease. So people with acute kidney injury, AKI, should focus on their kidney health with their care team's help. This will allow for the best chance of recovery. However, many people do not recover, so it's also important to be prepared for the possibility of kidney failure. Now, let's briefly talk about AKI. So this is the most common cause of AKI, or acute kidney injury, is acute tubular necrosis, which basically that's the most common type of intrinsic acute kidney injury in hospitalized patient. The cause is usually ischemic, meaning it's not getting any blood. Prolonged hypotension, or nephrotoxic, agent toxic to tubular cells. And so again, not to get too technical or scientific, let's say, all right, let me give you an example. Back in the 80s, when I started dialysis, I worked at a hospital in Virginia as I was a technician, and I worked as a coordinator, renal coordinator of that hospital. And this was back then when technicians could write orders for doctors excuse me, give blood, everything, work in the ICU. You can't do that now as a tech. But I kid you not, it was this guy, a white gentleman. I got called in. I was on call. This guy was from Tennessee. Him and his family, his wife and his little daughter, came up to Arlington, Virginia. And he was doing construction. And what happened, they found him on the hotel floor. He had shot dope. He still had the needle in his arm. The dope or the heroin shut down his kidneys, right? So they rushed him to the ER. I got called in to do dialysis because his kidneys shut down, his numbers up. And so we were doing daily dialysis. And so after about 2 weeks, so what happens, doing daily dialysis gives the kidneys a chance to rest, okay? And so after about 2 weeks, right, I kid you not, I come walking in the room. And this is like my first time doing acutes. Again, this was like 89, 87, 88. And I had started dialysis in 85. I come in the room and he has a Foley bag because, you know, kidney warriors would tell you when you go in the hospital, they're going to want to slap a Foley bag in you so they can measure that urine. So I come in the room. Each day, the bag would get fuller and fuller until this guy had about 1,400 to 2,000 liter output of urine. And the labs were coming back. They stopped the dialysis. They poured the catheter. Kidneys recovered. That's acute kidney injury. Or medication, nephrotoxic or kidney toxic medicine. Say you go in a hospital and they give you an antibiotic for something else and it doesn't agree with your body. That can shut down your kidneys. Strep can shut down your kidneys temporarily. It depends on the degree of injury that's caused from the situation. If you're in a car accident, any type of acute trauma can shut down your kidneys and they can rest and they put you on dialysis to give your kidneys a chance to rest. And then you got to the point where you can have acute kidney injury and you can have damage to the nephrons to the point where kidney failure may be inevitable, or you may have a critical decreased amount of GFR, glomerular filtration rate. And so we see this in dialysis units where the patient may still have urine output and you go to dialysis. They say, let's monitor. You got acute kidney injury and we're doing 24-hour urine creatinine clearance where we're giving you the jug and telling you to urinate in it each time and put it in the refrigerator and then bring it back into the unit and withdraw your blood. We're trying to measure the rate of urine clearance in the toxins out of the blood. For some patients, they still have enough clearance where the doctors could put them on 2 times a week, 1 time a week, something like that. And for other patients, you know, they go straight to kidney failure, unfortunately. But when you talk about chronic kidney disease, you're talking about something like diabetes or hypertension that affects the kidneys over the long term, which you go through those stages and you got a chance to halt the progression. But if you don't know about it, I mean, the damages are being done to the nephrons. And what a lot of patients don't understand, they still may have urine output, but the clearance is not enough. So in that case, you could talk to your doctors. The more you know, you could talk to your doctor and say, okay, if I still have urine output, maybe you might have 500 to 800 cc's of urine output. Talk to your doctor about maybe doing dialysis once or twice a week, because the more you do it, it seems like it knocks out the kidney function. So you just got to play it smart, or even go home and do home dialysis or peritoneal to maintain that kidney function. So again, the most common cause of acute kidney injury, right, is tubular necrosis. You're going to have to look that up. I'm not going to get scientific. I'm not a renal nephrologist, but I can tell you this is the most common cause, which most common type intrinsic acute kidney injury in hospitalized patients. You usually see patients to get heart transplant, major surgeries, stroke, heart attacks, whatever the case. And you can see because of the reduce of blood flow to the kidneys is going to shut the kidneys down temporarily, right? Some people recover, some don't. That's the bottom line. The cause is usually ischemic, which is a lack of blood, right? In this case, prolonged, which low blood pressure for a long period of time, meaning blood is not getting to the kidneys and perfusing them like they should be, and or nephrotoxic, anything that's kidney toxic that you may ingest, environmental, medication, disease like strep, a virus like COVID, okay? So that's when we're talking about acute. Now, end-stage renal disease, which we know that kidney disease has 5 stages. Once you get to that 5th stage, it's not exactly kidney failure. You still got a little time, but when you're not producing any more urine, or you get down to maybe below, let's just say 5%, because I think that's what the benchmark they're using, 5%. To some patients hold on, may not have any symptoms. Some patients get down to 10, 8, 9. 10, 9, 8, 7, 6%, and start having uremic symptoms. A lot of older people, you can see the yellowish. They may have white hair, and you may see yellow on the hairline. That's urine. You may smell it. You may see crystallized urine coming out of the skin. Edema, nausea, vomiting, fatigue. That's all comes down to kidney failure, which is end-stage renal disease. And that's where they get ESRD from. End-stage renal disease happens when the kidneys stop working completely. At this point, either a kidney transplant or dialysis treatment is needed to stay alive. Many people with AKI, acute kidney injury, end up with end-stage renal disease and need to remain on dialysis treatment or get a transplant. So let's talk about preparing for long-term treatment. People who continue treatment can live very full lives. The key is to choose the right treatment, which we all know, okay, for your life and your situation. All treatment types are not going to fit everybody's situation. Somebody may have to do in-center. Some people who may be doctors, police officers, may need to do in-center or home dialysis. Many people start treatment at a dialysis center, but that's not always true. You may start off at home. Again, the sooner you know about your condition, you can start the training before it actually gets to that point and not even go into the dialysis facility. But there may be other options that fit you much better, your life as well. Treatment options. You have choices. If you didn't know that, I'm not trying to play on your ignorance, but you have choices to make about your treatment. Don't settle for one. Hemodialysis is just one of many, right? Different choices that you can make. You may even be able to do dialysis at home or receive a kidney transplant, which we all talk about preemptive. All right? You can get on the list before you even hit dialysis, like so many warriors are doing right now. Take your health back. Okay? Think about these factors, all right? When learning about these treatment options, you got to think about the factors. Don't let them play you short. One, where would you prefer to have your treatment? If you're not on dialysis yet, if you're in one of the 5 stages and you're heading down that road, where would you like to have your treatment? Would you want to have it in the medical setting or would you want to have it at home? You have that choice. You don't have to just go in the medical setting. You don't have to just do it at home. You have that choice. Now, when would you like to have your treatment? Daytime or nighttime? Come on, guys. Take advantage of this. If you're not on dialysis and you're heading down that road, take advantage of this education. Also, how comfortable, which is important to a lot of warriors, how comfortable are you to do your own treatment? How comfortable are you? Independent, or you want to depend on a care team? And sometimes, you may not be able to do it by yourself. But also remember this. To err is human. And what I mean by that, humans make errors. Now, if you can't do it at home and you got to go into the clinic and trust somebody, right? Know what they know, right? Know what they know. And you may say, Steve, how am I going to know what they know? How you going to know? I'm going to tell you right here. Yes, I have that training manual as well. I have training manuals as well, right? And I can train you to know what to look out for. And so if you see something wrong that's being done to your treatment or not right, you can make the proper corrections. All right. Now, let's talk about catheters in this. Some patients have to have a catheter because their veins are shot. All right. But if that's not you, no matter what treatment option you choose, right? Replacing your CVC, central venous catheter, with a permanent access is critical. And I can't tell you enough how critical that is for staying safe and healthy. So let's just break it down. Preparing for life with treatment as I end this segment of education. While you adjust to life on treatment, you need to keep other parts of your life in order. If you are working, there are steps you can take to keep your job and finances secure. Taking time off through FMLA, sick time, or vacation. considered short-term disability, and also the ADA, employee rights through the ADA, American Disability Act. With that being said, let's talk about take charge of your discharge. I'll be right back with that right after this commercial or this PSA. What's going on? What's going on? This is your boy Steve Belcher, Urban Health Outreach Media. Thank you for joining me for this segment of Kidney Disease Education Moment. We're talking hospital discharge. Take charge of your discharge. Now look, for a lot of new warriors, I'm not talking about veterans, okay? Talking about for a lot of new warriors who just started dialysis and haven't been back to the hospital. Let's just talk about some things you need to know to take charge of your discharge if that happens in the future. So let's talk about this. 1 in 3. All right? 1 in 3. If you go in these Facebook groups, you will see a lot of patients talk about they're in the hospital or they went to the hospital. I see it all the time. So 1 in 3 may not seem a lot on paper, but when you go in these Facebook groups, our kidney warriors, they're in the hospital. Many. 1 in 3 hospitalizations result in another hospitalization within just 30 days of being discharged. Let me repeat that. 1 in 3 hospitalizations result in another hospitalization within just 30 days of being discharged. How many warriors got discharged and then within 30 days you find yourself back in the hospital again? Come on now. Let me hear amen. I mean, it's not pretty, but I mean, it supports the facts or the statistics. The best way to avoid going back to the hospital is to follow your discharge instructions. Take charge of your discharge by following these 3 steps. I hope you will start to feel better. 1, take charge of your medications. Do your discharge instructions ask you to stop taking certain medications? If so, stop taking them right away or talk to your kidney doctor. Do your discharge instructions ask you to fill new prescriptions? We all know patients get new prescriptions when they get discharged. If they do, get the medications from your pharmacy as soon as possible. Start taking your new medications as prescribed, but also take those medications in and go over them with your kidney doctor because you may be taking multiple medicines. Take charge of your follow-up appointment. Very important. Being discharged doesn't always mean you're done with treatment. Sometimes it can take multiple doctor and visits to get you all of the care you need. Do your discharge instructions ask you to schedule follow-up appointments? If they do, follow up on them. Bring all info from your discharge. Bring all the papers you get from the hospital to your dialysis treatment so the nurse can look at them and see, because you may have an infection in the hospital and they may want you to get antibiotics at the dialysis unit. But we won't, if you don't bring those discharge instructions, or if the nephrologist doesn't call us and tell us, we won't know. So it's very important to bring the discharge instructions that you get from the hospital, especially if you had an infection and you were getting antibiotics in the hospital. They may want to continue that treatment outside the hospital. Also, take charge of your discharge paperwork. Bring your discharge instructions, as I said, and all your medications. We need those medications to add them to your database, to your next dialysis appointment. The dialysis clinic needs your instructions so they are up to date on your care. Also, when you get discharged, when you know you're about to leave the hospital, call the unit and let them know you're about to get discharged, because if they don't know, right, and you like discharge and you go to dialysis the next day on your treatment day and they don't know you discharged and they didn't call the hospital to check, they may have gave your chair away. I've seen it happen. People, we didn't know someone got out the hospital and someone goes out to the unit technician and say, I just saw Mr. Johnson in the lobby. And we like, huh? I thought he was in the hospital. Nah, he's sitting in the lobby. Damn. All the patients are on the machine. And patient come walking in, discharged from the hospital, hour after everybody went on. We done gave that chair away. They done closed. We put them on. And let me tell you what happens in that case. They don't get their whole treatment time. 2.5 hours. We call the doctor. Can we run so-and-so 2.5 hours? They came here. We didn't know they was discharged. They run 2.5 hours. That's what happens. That's the serious truth. So that's why you have to be very vigilant in your care, especially when you get discharged from the hospital. Make sure you call the unit when you get discharged, especially if they didn't give you dialysis before you got discharged. If you didn't get dialysis, they said they're going to dialyze you at your unit, you better make sure they're expecting you, because a lot of people drop the ball when they do that. I'm just speaking the truth. So with that being said, I said I was going to do 3 things. That was hospital discharge. Now I want to come up on the third and final education moment right after this PSA. quick access check when you go to dialysis, when you're not at dialysis. And what quick access check is basically the look, listen, and feel method. All right. So each day, I recommend doing a quick access check. And again, it's 3 steps. Look, listen, feel. Look. Do you see any changes? I posted on my page, I have posted a picture of a gentleman, his access, it was crusted, infected, right? So that brings me to this point. When you look at your access, whether you have a graft or a fistula, right? Do you see any changes in skin color? Okay? Any redness? Any shiny skin? Any worn away skin? Any pus? Any crust or discharge? If you see that coming from your access, this could be a sign of an infection or a problem, and you need to let someone know immediately. All right? Immediately. Listen, that's where the stethoscope comes into play. All right? I got my earbuds on, so I'm just going to pretend like I got these in my ear. So again, you can use a stethoscope for this step if you have one. Don't fret if you don't have one. If you don't, simply place your ear next to your access, wherever your access is. Put it next to your ear and listen. Stethoscope, you want to place it on it, right? Of course, you want to wipe it off with alcohol, okay? You want to disinfect it and wipe your access off, disinfect that as well. Then put it on and listen. Now, what you're listening for? You may say, Steve, what I'm listening for? You got me with a stethoscope on like I'm a doctor or a nurse or a CNA? Or you got my ear up to my arm? What do you have me listening for? I'm going to tell you. You should hear a low pitch, continuous whooshing sound. Like whoosh, whoosh, whoosh. If you're watching this, you have an access in your arm. If you don't have a stethoscope, put it up to your ear right now and listen. If you have it doesn't matter if you have a graft or a fistula. If you don't have a stethoscope, you use your ear and listen for that whooshing sound. Whoosh, whoosh, whoosh. Or if what you hear sounds more like a pounding pulse or a whistling noise like a hot tea kettle, like that, your access may need maintenance. That means it may be becoming stenosed or a narrowing. It's starting to narrow the access. And that's why the high-pitched sound. That's why the high pressure, the high venous pressure, depending on where the stenosis is, right? High arterial pressure, -280, -300, -250. Or your venous pressure is 300 or 280. So again, you want to listen for the whooshing sound. Whoosh, whoosh. You hear that? You good. You hear that whistling like a tea kettle? Go to your access surgeon. Go to the person who put that access in. Okay? You know what I'm saying? Let me say this. If you brought your car from a BMW dealer, you wouldn't take it to a Hyundai dealer. Okay? You're going to take it back to the BMW dealer. So, the surgeon who did your access, and if it was a good job, and if you like that surgeon, go back to the creator. You see what I'm saying? Go back to the creator. Not somebody who doesn't know the creator's work. They may F it up. All right. The last part of this 3-step method or process is the feel. Gently rest 2 clean fingers on your access. 2 P's on your access. If it's in your leg, lower arm, upper arm, it could be in your chest. I've seen people with a horseshoe access in their chest. Gently put 2 fingers wherever your access is, right, on it, being careful not to remove, very important, not to remove any scabs that may have formed. You don't want to knock them off, because some people, if that scab come off, Lord have mercy, they got a gusher going on. Okay? They may start back to bleeding. If all is working well after you put your 2 fingers on your access, you should feel a continuous, soft vibration under the skin. Okay? Imagine you're holding a kitten. When the kitten purrs, you may feel a soft vibration. Your access should have a similar feeling. Again, if you see, right, redness, pus, drainage, scab, hear the teapot kettle, or feel anything strange, call your surgeon or dialysis clinic right away. I'm serious. With that being said, let me see the comments. I got 11 comments. Guys, you're not going to get this information anywhere else. And I hate to keep saying that, but I'm just trying to prove a point that we love educating, and we just need more people. We just need more people to educate. I know it's 11:45 Eastern Standard Time. Over in UK, it's 5 hours difference. In California, it's 3 hours behind. In Nigeria, it's 8 hours ahead of me, or 5 hours. Look, I don't care where you're at. Kidney disease is the same. And we got to get that information out there. I thank you guys for watching. Let me look at these comments. Oh, okay. I got somebody I've never seen before. Thank you for joining. God bless you. I'm not going to mess up your name and try to pronounce it, but I'm just going to call you Lyn. God bless you for joining me. I don't want to mess up your name. I want to try to pronounce it off screen. Let me see. You said, my husband started dialysis since last May. The dry weight needed to be increased. I have to have a conversation by telephone with the doctor about it, because every time he go in, been soaked dry. Okay, they're taking a lot of fluid off, and leg cramping is always. Since he is voiding and eating good, hemoglobins were at 5. Damn, that's low. Before dialysis. Okay, he had gone up to 9.4 with epigen therapy. Now, last lab notice had gone down to 8.4. What could be, if anything, is being the same proteins method? Okay, so I don't know what country you're in. One, if his hemoglobin is going back down, ask the doctor, or no, before you ask the doctor, check his stools. Check your husband's stools. I know that may sound gross, or ask him to check his stools and ask him to see if his stools, his bowel movements are dark, tarry. If they are black and tarry, okay. If his stools are tarry, he could be bleeding from the GI. And a lot of kidney patients have this issue with GI bleeding when they first start dialysis. Start right there. His iron stores can be low. His iron saturation. Ask him what is his iron saturation. His iron it needs to at least be 20%. Check and see what his iron stores are. His ferritin level, all that drives the EPO, all right? And that works in combination. If he has an infection, that could be a reason. If he's at dialysis, maybe they could have, on dialysis, he could have had a blood spill or something. I don't know, but just make sure you do all the initial checkup to make sure they ain't waste no blood. Nothing happened at dialysis, no blood in the stools. Check his iron levels. And they could have maybe held the epogen. They could have forgot to give him the shot. Who knows? But these are things to investigate. And about his dry weight, if he's cramping and if your husband been eating well, his appetite's 3 squares, his appetite is increased. Yes, if his appetite is increased, then you need to increase the dry weight. And normally, whatever they taken off, say if he, just for this conversation sake, let's say your husband dry weight is 50, right? Let's say he started dialysis and his dry weight is 50. I want to just use kilograms just to keep it simple. No, I want to use pounds just to keep it simple. And I know he may not weigh this low, but I'm just trying to keep it simple for the conversation. Let's say your husband's dry weight was, when he started, was 50 pounds because he got discharged from the hospital and his appetite was really low. He wasn't eating. And let's say since he's been on dialysis since May, you've been feeding him and your food is just off the chain, right? And he's been eating. Appetite is great. And let's just say the doctor hasn't been in to see him, right? And he set that dry weight still 50. Let's say your husband comes into dialysis, let's say 55 or 54, right? Let's say 55. And they say, oh, you're gaining fluid. And say they try to pull off 5 or 4.5. Yeah, he's going to cramp. Of course. What I'm saying, and he starts cramping, right? And they stop pulling the fluid. So say when he gets off dialysis and he go away, let's say he weighs out at 52. Say 52.5, right? And everybody like, damn, he didn't get down to the dry weight. Well, 50 probably is not the dry weight anymore. Okay? When the patient begins to cramp, that means we have gotten most of the fluid out of the tissue, right? And now you're going deep in the tissue and you got to replace that fluid, because when they cramp, that's why we give you saline, to replace the fluid that was taken out of that muscle tissue. So it's about that sodium balance and all that. And I'm not going to get into that scientific, but they need to increase the dry weight, maybe half a pound or half a pound, right? Especially if it's dry, if he's been eating a lot. And let me see. Hello, Yolanda. Thank you for watching as well. I appreciate you. Warrior, 30 years. Okay. I've been doing dialysis 33 years. So we've been in it. We've been in the game about the same time. God bless you and keep you in thoughts and prayers. Let me see what LYN says. Okay, I read that one. You said, please read the first comment. Okay, let me go back to the first comment. My husband is producing urine all day. He void unmeasured during the day. Just at night, volume is between 500 cc's to 800 cc's. I had a conversation with his nephrologist to reduce the amount of time. Also, I noticed on his labs that KTOV went down from 3.14 to 1.16. I read about it and something needs to be adjusted on the dialysis machine. Also, the creatine. Okay, you probably meant to say the creatinine has gone down since he started dialysis. Used to be at 16, and notice his labs, the numbers on changed to 6, but did not convince me. Please, it doesn't convince me that the fact the dialysis nephrologist doesn't always do the round every week. He does one once a week. There are so many things it doesn't make things when he. Hey, Will, thanks for watching. Yeah, now I didn't see that first. I didn't see that first comment. Now, if he's urinating, that's another thing, because he's excreting the fluid. So they may be trying to pull off something and it's not there. It may not just be the diet, but if his appetite is increased and if he's still urinating, that plays a big part. Iron went low. The decrease, they are not giving the same unit. So the EPO, EPO used to be 10,000. They are giving him only 8. My husband was 80. Now they increased 84. After they increased 86. Now it's 87.5. Okay, so let me tell you what happens with the Epogen. I'm not sure what state you're in. Excuse me. Lasulamita. Okay, Lasulamita. I hope I pronounced it right. And if I did, please accept my apologies for mispronouncing your name, Lasulamita. But what happens with the EPO? They use a reference range. So if the hemoglobin goes into a certain range, like your husband, he was getting 10,000. If his hemoglobin went up to a certain point, depending on what that medical doctor, what they set the range at, once it hits a certain mark, they decrease the EPO by 25%. So if someone's hemoglobin is 12, they may hold the EPO until it decreases. It's like a seesaw. They play with this. You may have your hemoglobin at 11 or 10, and there you may have been getting 6,000. They cut the EPO down to 2,000, and then they wait for it to drop to increase it back 25%. So it's a game. Numbers, Medicare, how much they reimburse. They're trying to get more bucks from the bank. More bang from their bucks. Let me tell you this before I sign off, okay? And I'll put my hand on the Bible. What I'm about to say. This is how low these companies go. Well, okay, I'm going to be fair about this and not say companies, but I worked at DaVita Union Memorial Hospital in Baltimore City, Maryland. And at the time I worked there, right, the administrator wasn't a nurse, but was a bachelor's degree administrator, right? Straight shooter, business. Her name was Tasha. She no longer works there. However, we didn't have any EPO, or they was waiting for some EPOGEN to come from the Bergen and I can't think of the name of that pharmaceutical company, Ann Bergen or something like that. She had us, after we, like, the little EPOGEN vials, we'll withdraw the amount we're supposed to get, and when you get down to it, we normally put them in the back in the box to throw them away. We had to put them in a container. The reason they did that, because they'll go in that container when it fills up, right? When the container fills up with the empty vials, they want the nurses to go back into those vials and get as much of the EPO they can withdraw out of those vials. Yeah, they do it. DaVita does it. They're not going to tell you that. Somebody like me who been on the inside and that worked for DaVita 19 years PRN. And I just left them working for them after my injury from February 2018 up until my injury, where I slipped on some acid in the locker room, right? That shouldn't have been there, Friday, July the 13th. And I could no longer do my charge nurse duty, only sedentary duties, sitting down, being chastised by my colleagues, talked about, right? And then ended up January of 2019 getting terminated. So if anybody knows about DaVita and what they do and the cruddy stuff they do, go on my page. You'll see the videos of where I used to work. You see the acid caked up on the pipes. You'll see it all. That's how cruddy this company is. And I don't care if they're in Boston, Massachusetts, Hollywood, California, Killeen, Texas, Baltimore, Maryland, Washington, D.C. I don't care where DaVita is. As a whole corporation, they are cruddy. And you heard it from me. So that's not speaking about the workers who work on the floor. I'm talking about upper corporate management who sees profit over patience. Right? Because it is. It really is. It's profit over patience. It is. I mean, anytime you have a company that has Warren Buffett as the lead shareholders, and we all know Warren Buffett doesn't invest in anything that doesn't make money. So, Yeah, to talk about it because I asked my husband every time he had doubts about how was the strength of the EPOR iron. So yeah, please, Lamita, please go to Urban Health Outreach Media, follow our page. This is my first time seeing you. God bless you for watching. Thank you so much. And thank you to the rest of the people who commented and watched. Yolanda, Manoy, Kathy. Hey, Kathy. Jim. Hey, Uncle Jim. Jonathan, Jared, Bridget, Will Porter. Who else? I feel they don't want people to cut hours of patience on the machine. Well, let me just say this. If your husband's still urinating, it's KT over V, is good. I would talk to him about once a week, twice a week, 3 hours, because the more he goes on, the kidney function is going to decrease. It's going to decrease. So you, his caregiver, Lasulamita, and the medical knowledge that you have, take charge. That's your right. That's the patient's right. You got rights and responsibilities. If you go to Urban Health Outreach Media and go to videos, we did a show on patients' rights and responsibilities. If you got that mission packet from DaVita, go back through that admission packet if you didn't look at it. And I'm assuming you did because of your medical experience. But go back through that admission packet and look for the patient's right and responsibility. You have a right. If you want to listen, if your husband wants to run, if he's still doing urinating and all that, and the KTOV is good, and you monitoring that, if you want to run 1 day a week for 4 hours, suggest that. That's your right. Look, you can do that. Push come to shove. You go 1 day a week, you run 4 hours, they're going to have you sign the AMA if that's not the doctor's order. You sign in, you go about your business, or you go home. Take the money away from the unit and go home. In fact, right, by you being a caregiver, CNA, and all the medical experience, I would do home dialysis. I would do, bar none. I would do home dialysis. I would stick the needle, whether he has a catheter, knee, fistula, graft. I would do that. I would take the place of the technician because you are capable. You're more than capable of doing it. If you a CNA, let me go back and look at this, and then I gotta go. I got somewhere to run, and it's late. Okay, here we go. You said, I am who take care of him. I am a medical assistant, nurse aide, and lab technician. Man, if I was your husband, shit, I would be doing home dialysis. Unless you got something that prevents that from happening, I don't know. I'm not in Boston. But I would be doing home dialysis. Anytime DaVita hires people that, and I'm sorry, I'm not taking anything away from people who have worked at Walmart or Dollar General. However, if they never had patient care, not patient contact or customer contact, I'm talking about patient care, like a medical assistant, taking blood pressure, temperature, pulse rate, understanding that concept of taking blood pressures every 30 minutes and why you need to do that. Nurse aide, lab tech. You a lab tech? I mean, you'd be a shoe-in to cannulate his access if he has a fistula or a graft. Man, you should be doing that. I'm telling you. Please. Yeah, yeah. I mean, bring your husband if you want to. If I talk to him, yeah, get him out of there. Absolutely. Look, I used to work for the Vita, like I said, 19 years off and on. Send me a friend request. I gotta go. I could talk to you for hours, but send me a friend request. DM me, Steve Belcher, RN. I'd be more than willing to talk with you. Again, tonight, I'm about to step out for a moment, but do that, and I can kind of help guide you. Of course, everything is left up to you, but I can just give you some pointers and just make sure you're in the right direction. Hook you up with some people that do home dialysis that could tell you that that's the best thing that they could have done for themselves. They ain't got to worry about being subjected to the staff smartness or somebody messing up or not pulling off the right fluid. You can do this. Jonathan Traylor, if you're watching this, man, you need to be on top of this. Jonathan Traylor, La Sulamita, he has a show called Hope with Jonathan. He's on Facebook too. And in fact, let me see if his name is on here. I thought I saw him earlier. Yeah, this is him, Lasuda Mita. He just got a transplant maybe 3 months ago, 6 months ago. He does his show, but his wife was his caregiver. You see how this works? His wife was his caregiver, right? And maybe Jonathan can talk to your husband, right? They both kidney warriors. I mean, bingo. This is why this forum is set up to network like this. So reach out to him. If not, I'll reach out to him and ask him to reach out to you. Send me a DM, friend request. God bless you for watching. Share information, La Sulamita, all across Boston if you can, about Urban Health Outreach Media, to the Kidney Warriors up in Boston, Mass, wherever you're at, and Massachusetts. Well, you did say Boston. Please let them know about our program. Thank you for watching. This has been an impromptu of kidney disease education moment. I talked about acute kidney injury, chronic kidney disease. I talked about quick access check, the look, listen, and feel method. And I talked about hospital discharges. So again, you're not going to get that from any other organization this late at night.